You are now watching the Quarterly Review Replay featuring Dr. Debi Dalton, sponsored by the Medical Association of Georgia.
Good afternoon, everybody. We're getting lots of people joining us now, so we'll keep an eye on that. I'm Debi Dalton, and I'm the president of the Medical Association of Georgia, and I thank you for joining us this afternoon for our my first presidential quarterly review. For those of you who don't know me, I'm a pediatric emergency physician and currently serving as the chief medical officer at Wellstar Douglas. I'll be moving to Wellstar Paulding in January. I just want to let you know some of the things that we're going to be starting to look at as legislative session is starting next month. And we'll be working on some tort reform issues, and truth and damages, homestead exemption, and some other things. And certainly we'll be watching to see what the legislators are bringing forth and what other groups are bringing forth, so we can adjust as we need to regarding those issues. Also, we'll be working on PBA reform. And just want to make a comment about the tragedy that happened last week with the CEO being murdered on the street, and absolutely awful thing that happened. I'm hoping we'll have some good come out of it, and looking at some of the practices of some insurance carriers and making sure that our patients are being covered, and hopefully, we'll have some good come out of that tragedy. All right, so this afternoon, we have Mr. Matthew Katz, who is the principal of MCK Health Strategies, LLC, and a consultant for the Physicians Advocacy Institute, Incorporated, where he has been previously a board member, and he works on research related to physician employment, healthcare costs, and changing landscape of medical practices. He has more than 30 years of health policy and advocacy experience working for health insurers, hospitals and health systems, and medical associations at the state and national level, including the American Academy of Pediatrics, which I'm a member of, and the American Medical Association, also a member of, and the Connecticut State Medical Society, where he was the CEO from 2006 until 2019. So thank you for joining us, Mr. Katz, and I will go ahead and hand it over to you to give us some information.
Well, thank you, Dr. Dalton, and thank you to the Medical Association of Georgia. It's good to be here and to share with you some information today that the Physicians Advocacy Institute helped collect. One thing I want to mention is that the MAG executive director, Jeremy, is on the PAI board and helps make the decisions on the research that we do. So anything you like about it, you can thank Jeremy. Anything you don't, you can blame me. But what we're going to share today is the data looking at employment of physicians, not only across the country, but more specifically in Georgia. And we're going to go into some specialties to show you the differences by specialty in Georgia. The Physicians Advocacy Institute, which I'm here today to represent, is a not-for-profit organization that focuses on really advocacy for physicians. And it was founded out of a class action settlement back in the early 2000s, and has been providing research and advocacy since that time. The PAI actually, in this study that we're going to be really detailing, worked with Avalere Health and a company called IQVIA, and it's IQVIA's database, their data system that we pulled from to look at physician employment trends in the US and Georgia. So it's important to recognize this is a reputable database, and we used a nationally recognized and internationally recognized company to really do the study. The study was to look at the transition of physician employment. And to level set a bit for everyone, and I think it's important to recognize these trends have been happening since 2012. We've seen some significant changes, but we saw an explosion in those trends really during the COVID time. But to put things in perspective, in 2012, we had 75% of physicians in independent practice. So 75% in 2012. By 2018, we were up to, so 25% employed. By 2018, we were up to 44% of the physicians in this country employed by a non-physician in some fashion. So from 25% in 2012 to 44% in 2018. Then COVID came along, and there was an explosion in physician employment. And so between 2019 and 2022, we saw the biggest part of the explosion, going from that 44% to 74% employment. But today, in 2024, we're at 78% of the nation's physicians employed by a non-physician entity, which is more than, and you see this graph in front of you, more than 500,000 practicing physicians today in clinical practice are employed by someone other than a physician, which is obviously very, very significant. And in 12 years, a more than complete reversal from where we were at that time. And it exploded during COVID, but it did not start during COVID. And there are some trends we're going to talk about in a minute that have changed since COVID, especially in Georgia. But it was kind of that point of, I don't want to say no return, because I think there is some returning to that independence, but I think it was a significant point in physician practice in this country, and some of the aspects of COVID and how it hit the practice. But there are a lot of things we can talk about today that are changing some of that. So that's the number overall. If you look at the numbers employed by hospitals and health systems, it's about 350,000. So of that 500,000 plus, 350,000 are hospital and health system. And I think it's important to note, PAI, nor I am saying that non-physician employment of physicians is a bad thing, but we are showing you what these trends are. And we're going to talk about some of the aspects that could be bad, good, or indifferent as well. But we're showing you trends. This is the trend. And you can see during really the tail end of COVID, there was pretty much a big jump in employment in those hospital and health system settings. If you
Matt, can I just interrupt you for a second?
Sure.
I just wanted to ask you, you will be talking about how it's not necessarily just health systems, but also venture capital as well that's going to be involved, right?
That is correct. In fact, this slide shows you that, Dr. Dalton, where you've got corporate entities. And by corporate entities, I mean health insurers, PE, and VC, PE being private equity, VC being venture capital. There's, kind of a distinction and without a difference there, but people say VC or PE, and health insurer employment, which is actually the vast majority of that 150,000 physicians who are employed by non-hospitals and health systems, is really health insurer based today, though we're seeing an increase in private equity venture capital. But yes, absolutely. It is not just the hospital and health system. And in many respects, those hospitals and health systems jumped in to help those practices maintain viability. It wasn't a bad thing. That's the trend we saw. But you can see there was a significant or rapid transition to corporate employment by non-hospitals and health systems during that same period. Absolutely. And in fact, a bigger growth. And we'll show you, and in fact, in Georgia has some differences compared to the rest of the country and what is shaping the market in those. Absolutely. So these are the percentages. 78%, as I mentioned, employed by non-physicians in this country right now. This just shows you 55% of that total is hospital, and then about 22-23% is corporate entities, which has seen the biggest growth in the most recent period. So let's talk a little bit about where the South is before we get into Georgia, if that's okay, because I think everyone talks about these national trends, but then they don't break it out by region or by state, and we're going to talk about that today. But you can see there are some differences, right? The Midwest predominant is by far from a regional perspective, got the most physician employment of all. It really is far and away the most, up well beyond 80%. While the South is, just reaching that 70% perspective. So you do have some variability by region, and it's pretty much been consistent other than maybe the 20 to 21 time period. It's been pretty consistent. When you then look at just hospital employment on its own without that corporate side, the Midwest again is at the top by far, and the South is lagging compared to the rest of the country when it comes to corporate. That's the PE, VC, and health insurer that Dr. Dalton asked about. So you can see South is on the low end of that, and hospital employment, and the Midwest is on the top end. When you then look at the corporate, it shifts, and the South has the biggest percentage of corporate, and the Midwest has the lowest. But one reason for that is you had such a high percentage of hospital and health system employment in the Midwest already. There wasn't many physicians for those PE, VC, and insurers to employ because they were already hospital based. But in a place like the South, where there was very little hospital employment back in 2019 and before, there were more physicians who were available for those kind of employment settings. So those PE, VC, and health insurers looked at markets where there was a large percentage of physicians who are yet employed by hospitals and health systems, and that's where they focused their time and attention. And you can see the variability here. Let's get to Georgia, because I think that's where everyone is here and is interested. So this is the Georgia map today, 2024. You can see hospital and health system is the predominant method of employment for physicians in Georgia, but it really hasn't moved much since the start of, since January 19 and COVID. You didn't see in Georgia as big of an impact, at least on the hospital and health system side. And you've gone from 47% to 50.5%. So the movement on the hospital side has not been that significant, and it's pretty much leveled out. Where you saw the big jump was corporate employment. And so you see independents going down and corporate employment going up, and now those lines kind of meet. So you had a different experience here. Most of your employment was corporate that changed in the last 4 or 5 years, as opposed to hospital health system. Again, that's slowly pretty much leveling off. And even with the corporate and the private equity side, insurer side, you've seen a leveling off the last 2 years, where you saw a lot of change, really July of 19 until 2022. The last 2 years, you've really seen in Georgia those trend lines kind of being stagnant, not much movement, which is, again, unique compared to the rest of the country, that we're seeing still a lot of change everywhere else, but Georgia has leveled off. Now let's look at the different types of employment. Hospital and health system. Just for everyone on the Zoom, on the telecast today, Georgia is the blue line. So you are today in between where the South is and where the nation is when it comes to hospital and health system employment. You are a little higher than the South, and you are lagging the national in hospital and health system employment. When this trend line started, it was a little bit different, but today that's where you are. About you're pretty consistent with the South, which would be expected. You're in the South, and lagging the national with hospital and health system employment. The corporate entity, the thing that is really, I think, interesting today, and where we saw some big movement, you'll see in Georgia, you saw a bigger increase in employment in those corporate entities than at the national level. But you are actually lagging the rest of the South, which means there's more corporate ownership in other states in the South compared to Georgia. Independence, because I want to show again, you're squarely in between the national and the South. And by the way, the South has Texas in it. So I'm sorry for all of you in Georgia. We had to put Texas somewhere, so we threw them in the South. They would have preferred to probably be on their own, but we put them in the South. They are a big part of the South because of their size. So they do play a more significant role in the South dynamics than most other states because of their size. But again, you're pretty much in the middle. So you are today, about 76% of the physicians in Georgia are employed by hospitals, health systems, health insurers, or PEVC companies, and 24% are independent, which is there's more independents than the rest of the country, but not as much as the South overall. And again, Texas is pulling that down in some respects. So let's look at raw numbers, because some people like seeing numbers as opposed to percentages. So in 2019, you had 7,893 clinically practicing and billing physicians that were employed by health systems and hospitals. You had 2,527 that were employed by corporate entities, and you had 6,271 that were independent. In January of this year, you had over 9,000 now employed by hospitals and health systems. The corporate entities, as we mentioned, went up the most. They almost doubled to 4,600, and independents went from 6,200 to 4,300. Now, that's pretty consistent in some respects to the national. If you look at down below on this table, you can see that your increase in health system was less than the national increase. Your increase in corporate entities was more significant than the rest of the country. But overall, and then decrease in independence is pretty close to the national. So in fact, you're seeing a little less loss of independence than the rest of the country. You're seeing a bigger increase in corporate and a smaller increase in health system. But I really think that's because hospitals had a higher ownership percentage at the start of this study than in other parts of the country. So that's why you're seeing it more in the corporate side of things. This just shows you another way of looking at one of the things that Dr. Dalton and I talked about was different specialties and different specialty areas. So the dotted green line on this map, on this chart, is the national information. And anything above it has a higher percentage of employment, and anything below it has a lower percentage. And so if you can see here that in Georgia, you have medical specialties and surgical specialties above the national employment average, while with primary care and pediatrics and other specialties, others being radiology, anesthesia, you're below the national average. So your medical specialties, your surgical specialties are above when it comes to employment and overall, and your primary care and your pediatrics and some of those others are below the national average. When you look at just hospital, it's about the same, though the lines dip a little bit. When you look at corporate, you've got pediatrics, interestingly, above that line. It's the only one that trailed up at the beginning, but most everything is above when it comes to corporate, again, because of the overall trend in Georgia. But you can see how it does differ a little bit by overall specialty category. But then what I thought would be interesting would be to show some, if it's okay, Dr. Dalton, some individual specialties in the last two and how they compare. So what I've got here is I've got the pediatricians, not just pediatrics, but just a subset, the pediatricians, and you can see where their employment is and the transition. They did see corporate entities going up. They saw independents going down and health systems going up a bit. But so pediatricians are pretty consistent with the overall Georgia trend. Not much of a difference, but you can see the percentages there. But then when you look at internal medicine, the same kind of thing, the primary care specialties, pretty much following that same trend of what you're seeing in Georgia, except much less corporate employment of those primary care doctors than the average in Georgia. You see it's roughly 17% versus the almost 25% of all doctors. Then if we look at emergency physicians, also only 10% of ER docs in Georgia are corporate employed. And you've got the majority that are health system employed, but there's a high percentage of independents still at 40%, 41%. And it's kind of ping-ponged up and down a bit. So it's not like that general trend we saw of the nation and all of Georgia. You see it up and down, which reflects not a standard trend, but some kind of fighting as to where those ER docs in this case are going to be employed, hospital or independent. And they're back and forth. There's ups and downs. It's not linear here. Then we look at dermatologists. traditionally independent and still very much independent in Georgia, but they're also very corporate. Almost 50% of dermatologists in Georgia are now employed by a health insurer or private equity or venture capital. That's really high compared to the other specialties. Dermatologists, again, nationally, you think of independent, small practices, but in Georgia, almost 50% are employed by corporate entities, and only 17% are employed by health systems. If we then jump to orthopedists, you see another trend where independence is down to about 11%, much smaller than the rest of Georgia. So independence is really low for orthopedists. And what's really high, interestingly, is, or not so interestingly, I guess, is corporate entities. But again, that fight between, do I work for a health system or do I work for a private equity health insurer? And so very different than the primary care trend, very different than the overall Georgia trend. So you've got some variability, and Georgia really, even though we say it's matching the national trend, by those individual specialties, you've got variability and some decisions being made by doctors that seem to be causing them to jump from one employment setting to the other, back and forth, not once and done, which is interesting because that lends itself to assistance, because if they're needing to transition and transitioning more, they may need more help and support from the medical association. This is Dr. Dalton. This is the Physicians Advocacy Institute website. I went very fast and went through a few slides, but there's more slides up on the PAI website, and I know Mag has the entire Georgia slide deck. So if anyone missed slides because I went too fast and I wanted to see some additional slides, I know that those will be posted on your website, Dr. Dalton. And hopefully we can, you and I can engage in some discussion and then open it up to others.
Great. Yeah. So thank you for sharing all that information. It's great. And I know you have a lot more information to share as well. So certainly as we discuss this and take questions, if you think of something that might be on another slide that you have, that'd be great if you could share it. If not, that's okay. So, it looked like the trends that you showed us started kicking in before COVID. Certainly seems like COVID hastened it a bit as well too. Anything you want to add about that? I mean, I know we're all probably tired of talking about what COVID did to us and all, but I just think that there was something that kind of accelerated it a little bit. Anything that you could think of that came through in the trends that you had found?
Yes, actually, well, COVID did have an impact, but you're absolutely right. It started before COVID. So we can't just say because of COVID or if not for COVID. It started before COVID. The Physicians Advocacy Institute did another study looking at and asking employed physicians why they transitioned and what concerns they had with the transitions. The why was very interesting. The two things that stood out was cuts in governmental and commercial insurance payments. So at the same time that we were experiencing COVID, physicians were experiencing cuts or lack of increases from Medicare, Medicaid, and commercial insurers. And so a vast majority of physicians, when polled, said it was these cuts or lack of increases in payments. So I've got all these things like COVID hitting me, normal cost of business, normal transition, and now I'm getting cuts in my reimbursement. That's number one. Number two, those same physicians said the cost of technology, the cost of new equipment at the same time was overwhelming. So they needed new equipment, they needed new technology. EMR was one of those things, and is still, but 5 years ago was one of those things that they said they have to adapt, they have to put in place, but it's so costly. And so they're seeing a cut in reimbursement. They're seeing a need to spend tens of thousands or more on EMR and other technologies. And then you had COVID at their back door. So you had unfortunately these three things happening at once. And I can't tell you which one was more impactful, but if you ask physicians, they say the number one reason was the reimbursement cuts or stagnation that caused them to transition from independent practice to some form of employment.
Yeah, I'm sure between that and then how expensive everything has gotten, even just everyday equipment that physicians use in their practices, that has skyrocketed recently, of course, as well as the cost of employing people. Just paying people their fair salary these days, I think it's a little bit different than it was even 5 to 6 years ago. So I'm sure that impacted it well.
Absolutely. And those benefits are another thing that they, not just the salary, but the benefits and, of course, health insurance. We all know in the business we're in, health insurance has mushroomed, and the high deductible health plans, at least until recently, also skyrocketed. So not on this study, but other studies that are out there talks about the increase in bad debt for physician practices doubling or tripling over the last few years because of the high deductible plans. So you've got the cost of your employees, just the basic salary, you've got their benefits, you've got this increased patient bad debt, you've got the cost of equipment, and you've got the lack of reimbursement. It's crushing. And so
Yeah.
I think that's why we have seen such a dramatic shift over the last few years. And, there was things that were done during COVID to help try to insulate in some respects, but it wasn't really paying doctors more or paying clinicians more. It was just trying to keep things open and operating. And unfortunately, that just meant more costs, right? It was,
Right.
we maintained access. We did, physicians did, you and your colleagues did, but at what cost? And unfortunately, we've seen the cost of staying open with lack of reimbursement increases.
And my understanding also is that banks are not as forthcoming with loans for physician practices, and they're not as forgiving with regards to payback from the physicians' offices.
Absolutely. It has definitely shrunk. And so there's fewer opportunities to get that line of credit, that loan. Physician practices used to be seen as the gold standard for sustainability and solvency. So every bank was fighting over you to give you a loan to be your bank of choice. Today, that's not the case. They're pulling back from physician practices. So not only do you see, because of the economy, those percentage paybacks going up, the interest on those loans going up, but there's fewer available. And those small banks have almost eliminated the loaning to practices. You have to go to that big bank that's less friendly, not maybe as local, and charges you higher interest. So that puts more pressure on as well. Absolutely.
Yeah. I'm just want to encourage everybody who's on the call that if you have any questions and if you'd like to put them in the chat, please do so at this time. And I'm going to ask another question while we're waiting for some other questions to come through. You mentioned the neighboring states having their experience is a little different than Georgia. Can you glean any information from the data that you have as to why Georgia has not gone as far as other states that are neighboring with regards to becoming more of a employed by health systems or venture capitalists and others as well, rather than being independent?
Well, so I think, each state is different and unique. Their regulatory and legislative environment definitely play a role. In some states, the medical liability climate has changed significantly as of late, some for the worse, and that has had some impact. Other states have regulation that limit the corporate practice of medicine. Texas and California are two that come to mind. They have strong corporate practice acts that limit those corporate entities, venture capital. They allow hospitals and health systems, but they don't allow those corporate entities as readily to employ physicians. So Texas and California are two of those states with the least amount of corporate employment and overall employment as a result of those regulatory things they've put in place that some other states have tried but haven't gone as well. I think also Georgia is got a very big urban center in Atlanta, but then it's also very, very rural. as you all know, in Georgia, there's a lot of rural parts of Georgia. Well, there's been significant hospital closings across the country and a lack of employment of physicians in these smaller communities and smaller hospitals. So it's very possible that because of the dynamics of one very large urban center and the rest being rural, you've had a different dynamic than, let's say, Florida with multiple urban areas that have seen more significant employment, because there's the urban areas where probably these companies see that they can buy bigger practices that are slightly bigger than in the rural locations and maybe more profitable. And so you see states that tend to have more urban centers outside of California and Texas, as I mentioned, because of their laws, but places like Florida, places like Illinois, places like Michigan, where there's more urban centers, they have significantly more employment. So it could be just the dynamic of urban versus rural. It could be that in Georgia, as we saw early on, there was more hospital and health system employment, and that actually may have insulated the rest of the market from this corporate employment. You are seeing a increase in corporate employment in Georgia, and it's a higher percentage than most states of increase, but it's still a lower percentage of overall corporate ownership. And that could be, again, because the hospitals were insulating because they were willing to employ doctors or purchase practices. So these PEVC companies and insurers didn't have those practices to purchase. But it's really hard to, Dr. Dalton, to determine which one of those, because the studies didn't look at that. But there is some differences in Georgia that likely led to that difference compared to the neighboring states, Texas, Florida, Mississippi, South Carolina. I mean, there's differences going on. I think when we look at Texas and we look at California, it's definitely the regulatory climate and the protections or requirements and some restrictions that were put in place for corporate employment that has done well for them. Now, a state like Connecticut, where I've lived for the last 20 years, this state has a corporate practice of medicine provision, but it has kind of been illusory. It's been ignored, especially when there are certain individuals involved that are political in the state and they buy a physician practice. Somehow they don't go through the same rigor review that others do. So we have had a significant employment by corporate entities in the state, even with what appears to be on paper a relatively strong regulation. It's just not been enforced. But in places like Texas and California, it's been actively enforced by active attorney generals or commissioners. And so there's been a little more insulation in those states.
Understood. Okay, can you speak a little bit more to any of the concerns that you have as physicians are losing more and more autonomy and working for other entities, other than having their own private practice? Anything that you could forecast that you maybe saw in other states?
So, some of the things we have to be worried about from the studies that the Physicians Advocacy Institute did in those employment settings is loss of clinical autonomy. More than half of physicians who became employed, regardless of the employment setting outside of that physician-owned practice, have said that there's been a loss of autonomy. That concerns me. That concerns Physician Advocacy Institute, and I am assuming it would concern all of you, that there would be a loss of autonomy. But what does that autonomy mean? Well, it means they can't refer to who they used to refer to. They have to refer in system or in with the insurer's network and not where they would normally refer. It also means that they have been incentivized to change the type of care or care options for treatment that are lower cost. Now, we all like lower cost, so I'm not saying that lower cost is a bad thing on its own, but if it's a perverse incentive to drive towards lower cost and not in the patient's best interest and not what the physician would normally do, that's problematic to me. The other things that the study showed was that physicians have lost time with patients in these employed settings, in these corporate settings. So they lose the time with the patient they lose the connection, they lose the communication. And so that's, to me, that's bad patient care if you can't communicate with your patient or you don't have time to do that. And that volume is dictating and not patient care. Now, I'm not saying these doctors are bad doctors, nor are these entities bad entities. But what the physicians are saying is that they're not able to practice in a way that they're accustomed, and it's jeopardizing patient care.
All right. I agree. Do you know what other states are trying to put in place to help protect the patient-physician relationship? Anything you can talk about with regards to that?
Sure, there's some stuff happening nationally and locally. So at a national level, Senator Wyden and Sanders, more left of center, have proposed some things in Congress. And Senator Warren and Markley from Massachusetts, because of some recent failed employment situations in Massachusetts, have suggested some things. However, those are all Democratic senators, and with the transition coming up in January to a Republican-controlled Senate, I'm not sure those Democrat-only bills, and I like some parts of them, some parts I don't, but those bills are going to go anywhere. I would hope, though, that some senators would get together and look at some of this. And, is regulation needed? Yes, but we don't want to have too much regulation. I'm not suggesting someone checking on someone daily or some entity daily, but there should be some basic standards when it comes to these employment settings and some penalties or prohibitions if they don't meet those. And what should remain the core of all this is the patient-physician, physician-patient relationship, right? So the physician can't practice, is being forced to practice in some way that's inconsistent with how they were trained, how they have practiced. That becomes a problem. But it's also very hard to regulate that, right? It's hard to regulate when practice is being changed. But I think some basic barriers basic guardrails need to be in place. So if you meet these and stay within these guardrails, it's okay, right? But if you go beyond them, if you have perverse incentives that only focus on cost and not quality, if you don't allow doctors to see patients more than 5 minutes, those are the kind of things that we should say are those rails that you can't go beyond. You have to stay within. You have to protect to keep going. So those federal laws are out there, and there's some good language in some of them that look at banning entities to sell their assets or sell the practice's location or just buy the practice for the real estate. There's some things there that I think are important. Some things that the Physicians Advocacy Institute recommends, and their guardrails are making sure that there's not only some oversight at the acquisition stage, but ongoing. I don't know any state that goes back and looks to see what happened with that practice that became employed, or those 100 physicians that are now working for a health insurer. Are they all still there? Did they close all those rural locations and now they've just got one big mega urban location and no one has access now in the rural areas? Did that hospital or health system get rid of all of the specialists and only keep the primary care? I mean, what has happened? No one is going back and looking. So there's no protection long-term. Even the California and Texas laws talk about the upfront requirements and restrictions. No one's going back and looking to see what's happened to medicine, what's happened to patient access. And, it's those business decisions that we don't want driving patient care. We want patient care to remain in the hands of the doctors, and business decisions about new equipment, new location potential, should be there, but it shouldn't override the patient's clinical decision making. And so at a state level, those corporate practice and medicine acts, there are some laws that some states tried to put in place, and in some cases governors have vetoed, that would have put some of those solvency restrictions on there, would have even put, and whether you agree with or don't agree with these do not compete types of signed agreements, also address some of those, because some of those are so restrictive that if a doctor decides this is not for me, this type of clinical practice is not for me, and I want to go back or go into something different, to have a restriction that says 5 miles that or says, excuse me, says 50 miles, um, or a certain time element. You in a place like Connecticut, you're in New York, Massachusetts, or Rhode Island in 50 minutes. So that means you have to move to a different state if you want to clinically practice. Those, I think, obscene restrictions have to go. I think a legitimate restriction may be 5 miles or 10 minutes away because, they did commit to buying the practice or employing you. So you have to give some understanding of clinical practice and the dynamics of their purchase. So you then maybe recognize there has to be some restriction on your transition somewhere else. But 50 miles, I mean, no one goes more than 20, 25 miles for care, even in rural areas. I don't know how you put a 50-mile restriction on a doctor, but they do. And so those kind of things are what states are looking at, so that a doctor who has made an informed choice, or maybe not so much of an informed choice, and then is reconsidering that, has a place to go and can clinically practice. Because what we don't want to have is all of these disgruntled doctors, and as the study showed, almost 50%, and having no place to go and no one to assist them to go there. So that's a problem. And many of these doctors don't have a practice to go back to, right? Because they sold their practice, their building was closed, but they still want to practice rheumatology. But where do they go and how do they get there?
True. Thankfully, George is working through the restrictive covenants that have been enforced for so many years. So that's a big plus coming our way. Okay, anybody have any questions online that we know of, Josh or Jeremy?
I don't see any questions at the moment.
I've received one question. Matt, in your slide deck, do you specifically have any data focused on OBs?
I do, and I can get you OBs both nationally and in Georgia. I don't have that easy to pull up right now, but I can easily get you the OB information. And it is different than primary care and specialty care. It's got a different trend line, and it varies by location. So there are differences and distinctions and that's one of them where there's a pretty significant difference.
Great.
And I'll send it your way, Jeremy, so you can get that, post that. But I do have the OB information as well.
Yeah, that'd be pretty important information, I think, for our state, especially. We have so many counties that don't have an OB, and a lot of legislation that came our way over the last couple of years that made it very difficult for OBs to practice the way they would like to.
Well, and there have been, I think, over 30 hospitals just this year alone that have given up labor and delivery. And with the prohibition that exists today on physician-owned hospitals, it's not like doctors can take over those facilities and keep the centers open. So whether it's a birthing center or something else, has to be options. And in many states, that's a restriction. It's another one of those things I don't fully understand why doctors can't own hospitals. They created them, centuries ago in the first place. And if a hospital in a rural area is giving up, whether it's OB or cardiology, why can't the cardiologists in the community take that on and over? Why can't the OBs take on the labor and delivery? It's one of those arcane things that came about in this country that still baffles the mind as to why can't those that provide the care and know the care the best own and run those facilities. And so, but we are seeing in places like Connecticut, we've had 4 hospitals ask the state to give up OB, and they've approved 2 of them. So we have deserts now in a small state like Connecticut where we don't have any hospital providing OB services. I can imagine in Georgia, it's probably even more significant from a distance perspective where there aren't any OBs. But in Connecticut, when those hospitals closed because the doctors couldn't take on that responsibility legally, they left those areas. So there is no one. Why would you stay as an OB if labor and delivery closes in your local hospital? You've got to have some place to deliver. So you've got to move your location. So the small towns and communities lose their OBGYNs. And, you're not going to see nurse midwives or anyone else showing up in those areas either because there's no hospital.
All right.
Great. Thanks, Matt.
I'm sorry, Jeremy, did you want to add something else?
I was just thanking Matt.
Yeah, and I want to thank Matt too for sharing all that information, and we'll be able to send that whole slide out to all of our members who might be interested in looking at some of that data. And certainly if they have any questions, they can direct it to myself or to Jeremy as well. And we can get that to you as well, Matt. And I see Dr. Callan's put a comment in that impact is reflected in our poor March of Dimes report.
After?
Sorry, Dr. Callens, I just put a comment in that the impact has reflected in
I have not seen
in our poor March of Dimes report. Sorry. All right.
No, that's okay. Yeah, access is a problem, and with OBs, it's a significant problem. Georgia is not alone in that respect, for sure.
Understood. Sadly. All right. Any other questions anybody might have? Well, thank you again, Matt, for sharing all that information. It was very timely, very important information, and hopefully we can work off of that as well and see how we can improve our state here in Georgia. Well, for those of you who are still on the call,
Thank you all very much.
Go ahead. Go ahead, Matt.
I was just going to say thank you very much, Dr. Dalton and Mag, for the opportunity, and make sure to get you the OB information and give you the other slides so you can post it if anyone has any additional questions.
Thank you. Thank you. And for those of you who are on the call, just remember February 5th is Doctor's Day at the Capitol. And so bring your friends and your colleagues and your partners and your white coats, and let's show our strength, and hopefully we can make a difference this year. Any last words, Matt or Jeremy?
Thank you, Dr. Dalton, for your leadership at MAG. You certainly hit the ground running, and we're very grateful for that fact. Matt, thank you for the data. We hope to have you again when the next set of data comes out, and thank you all very much for your time.
Thank you for attending.
Good night.